So what do you know? You may start the session.
I can start.
Yes.
Good afternoon, doctors.
How
Uh,
long? How long?
it should be or maximum maybe 30, 45 minutes.
30 minutes we finish.
Yeah, okay.
Okay, because it will become long, prolonged.
No problem, sir. Any slides, sir, if it is repetition, you can always tell me to jump. I will go ahead.
Okay.
Good afternoon, doctors. Welcoming you to this webinar on Carbetocin in action. Doctors from Heathrow Healthcare. Heathrow Healthcare has 25 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally and we are amongst the largest manufacturers of ARVs, API and FDFs in the world. Heathrow Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties. Heathrow Healthcare is pioneering in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar with Carbetocin in action. We all know that Carbetocin is used in prevention of PPH, prophylaxis of PPH, and we know PPH is a potentially dangerous condition and the role of Carbetocin. Although there are many papers and guidelines on Carbetocin and PPH, we always like to have our own doctor's experience and insights or use of Carbetocin. For which today we have got Naseer Syed, Dr. Naseer Syed with us. Welcome, Dr. Syed.
Welcome. Thank you.
The Naseer Syed Ahmed is MBBS MD obstetric gynecology. Sir has done fellowship in gynec oncology at Tata Memorial Hospital, Mumbai, and fellowship in advanced laparoscopy. Dr. Naseer Syed, Dr. Syed Naseer Ahmed is associate professor of obstetrics, SKIMS Medical College, Srinagar, medical director, Sheikhul Alam Hospital, Srinagar, managing director, Fertility Center for Fertility, Srinagar. With this brief introduction, I welcome Dr. Syed Naseer. Welcome, sir.
Thank you.
Over to you.
So today we are here with a very important topic. That topic has been there since mankind, I suppose, and has been an enigma and has been a problem for the gynecologists and for the mankind since then. There have been a lot of improvements, lot of things done, and but still the problem is there. That is what I am talking about, the postpartum hemorrhage. Postpartum hemorrhage is an important event that happens in the during the delivery of the baby, and it is a very important cause for maternal mortality and maternal morbidity and other problems associated with it. So there have been a lot of advances in the management of PPH, and there have been various. If we classify it, we can say that PPH means the postpartum hemorrhage that occurs once the baby is delivered can occur because of number one and important is etonicity. Means the uterus that is already very well stretched because of the pregnancy has to come back to a certain level so that the tissues and the vessels are tonically contracted and the bleeding does not occur. And if it does not happen, uterus does not come back to its desired level, then it starts bleeding, and that bleeding is torrential, and that is devastating, and that can be catastrophic in the event of non-management or in the event of not prompt management. Then there are other causes of it, like trauma during birth. That can be cervical trauma, that can be trauma to the uterus, like rupture uterus, that can be trauma to the vagina, that can be trauma throughout the birth canal, which can be induced, self-induced, or it can be because of the inappropriate management during the process of labor. So third is that there can be retained tissues like placenta bits, like membranes that remain inside and that can cause PPH. And there can be things like coagulation disorders and which can complicate the issues. But all other things like the trauma, like the tissues within it, like the thrombin, and these are the things that can be managed and that can be seen. But atonicity is the thing that can happen to anybody, anytime. Atonicity is the main cause. It accounts for 60 to 80% of all the PPH cases, and can happen even if we take certain measures, even if we anticipate it, and even if we don't anticipate it. That is why most of the things, like if you have a trauma, you know that trauma has been here, you can do an EVA and can stitch the things. If it is a retained product, you can do a DNC and you can evacuate it. And if it is a thrombosis problem, you can do other things. But in this case, it can happen to anybody. That is why most of the emphasis has been laid on the management of the this atonicity. That's why there have been many guidelines from the WHO and various other organizations to minimize this situation. That's why WHO in 2012 and 2018 came with guidelines of active management of third stage of labor, whereby three things were advocated and those were implemented, like use of utrotonics. Out of that, the most important was the oxytocin that should be used at the. It was recommended at the time of the birth of anterior shoulder or after the birth of the baby. You administer utrotonics so the uterus contracts. Second, the control cord traction means actively you pull in the cord and help the placenta to get out. And third, there is doing the uterine massage. But the utrotonics have definitely improved the outcome of the PPH in atonicity. So the various drugs used, the most important one is the oxytocin. Oxytocin recommended dosage was 10 international units to be given to the patient once the baby is delivered or anterior shoulder is, it reduces the blood loss and it increases the tonicity of this. Then thereafter, there came various drugs, like there was a ergometrin 0.5 milligram that has to be used, and it also reduced the PPH incidences. And combination of oxytocin and ergometrin was symptometrin in a fixed dosage was is also being used, and also the drugs like misoprostol, carboprost, they are also being used for the PPH. But the thing is that the PPH, the drugs used in the management of PPH, all have certain problems with them. We have a drug like oxytocin, that's the gold standard and has been used for years together now. The problem with the oxytocin is that it is a heat labile drug, and in a country like ours, the cold chain maintenance is a big problem. The storage is a big problem at many places, especially at the places where it is most needed. Means in a rural, remote area where the patient is already anemic, has not had enough antenatal visits, it has not been fully evaluated for the risks of PPH, and that patient lands with us, and we may have a oxytocin that has already been exhausted because of, that has been rendered ineffective because of its poor storage. That's the real problem with the oxytocin we have. Second is that oxytocin has to be infused in continuous infusions. Means you don't have a fixed dosage regime for this. It has to be continuously administered intravenous. And third is that it has to be used for prolonged periods of time. It has to be used continuously, and that leads to many side effects of it, like you have flushing, you may have a hypotension, you have tachycardia, you can have warmth and other problems. The main problem with this is that it has a shorter half-life. The main problem with this is that it has to be stored with a cold chain at 2 to 8 degrees centigrade, and that is to meticulously maintain. That is not possible at various, I should be saying various centers in our settings. Then if you see ergometrin, yes, it's a drug, 0.5 milligrams we used to give, and it is a good drug. It leads to usually the tonic contraction of the uterus, but it has side effect profile is not so good, and it can cause hypertensive problems in patients, and is contraindicated in those patients where you have the risk of hypertension. Third is that we are using misoprostol. orally it's a weak oral eutotonic, and it has a problem with it that it has to be given sublingually, or you can give orally, and you can it has a problem with it can have side effects like flushing, like vomiting, like tremors, and sometimes it can cause the cardiac events like renal this cardiac this vascular spasm. So there has been a continuous surge, continuous trial, and continuous efforts by the medical fraternity, especially the pharmacological fraternity, to reach certain molecule that can give a certain stability regarding the utrotonicity. So, fortunately, one molecule that has come in vogue nowadays is carbetocin. Carbetocin is now becoming more popular with the patients, and because carbetocin can cause uh, carbetocin is a drug that is the analog of oxytocin. You know that oxytocin is a drug that is manufactured from the posterior pituitary. It has a utrotonic effect, and second, it has a it is a utrotonic. Finish up with this. So, if we carbetocin is a the oxytocin is usually secreted from the posterior pituitary, and it has a utrotonic effect. It has an effect on the vasopressin V2 receptors also, and has an antidiuretic property also. So now there the to overcome the shortcomings of oxytocin, that is shorter half-life, heat lability, continuous infusion, no recommended drug dosage. So, and third, more cardiac instability. So, and its anti-diuretic action. In order to overcome all this, there has been a synthetic product that has been manufactured and marketed and is being not only evaluated, is being used now instead of oxytocin, which is superior to oxytocin and has a superior profile compared to ergometrin, misoprostol, and other utrotonics. It is it's a synthetic derivative of oxytocin. Advantage is that oxytocin is a shorter half-life of 2 to 10 minutes. It has a half-life of 40 minutes, and it has a fixed dosage. It can be given as 100 micrograms per ml solution that can be given either IM or that can be given slow IV bolus. Sometimes, let me correct here that small 1 millimeter, 1 ml of IV bolus may be cumbersome to you. You can take this and you can take carbetocin 1 ml and you can dilute it into 100 ml of normal saline and infuse it. Within a period of 1 minute or 2 minutes, it has a prompt action. You can use it IM also. The difference between the IV and IM is that IM it may take some time for the action, but IM action is more prolonged compared to the IV action. But you can use both IV and IM carbetocin. Carbetocin is a fixed dosage regime. You can give a single dose. Oxytocin, you have to give continuous infusion. Carbetocin is heat stable. It has been seen that carbetocin can be kept it can be kept at a shelf life of if it is 30 degrees, it can remain there for 3 years. If 40 degrees, it can remain there for 6 months. If it is more than that, it can. If it is 50 degrees, it can even for 1 month. That means it has a good storage profile in conditions where the hot environment is rampant. So, second, it can be given fixed dosage. And third, it has been seen that carbetocin does not have an effect on the as V2 receptors. So, antidiuretic properties like the retention of fluids is minimized with carbetocin. If you take ergometrin, ergometrin has also some heat lability. It has a hypertensive problem. It can not be given in PIH patients, and but there have been many research, and there have been randomized control trials and even Cochrane reviews where the latest it has come. Previously, we used to say that carbetocin is a drug that can be not be given in cardiac patients, that cannot be given in PIH patients. But we have many randomized control trials going on, and they have proved that carbetocin has a better cardiovascular profile compared to oxytocin. It causes less flushing, it causes less hypertension, it causes less palpitation, and it causes less ECG changes. And accordingly, it has been used in patients with severe PIH and patients with preeclampsia, and it has been seen to be more effective and more better than other drugs in these cases. And it is being used for these conditions also. So we have a drug now, carbetocin, which is available with us. The only the only problem with carbetocin is that it is somewhat cost effective. Maybe in coming days, the cost may come down and it will become available throughout. Cochrane review shows, many Cochrane reviews have shown that it reduces the average blood loss. You know that pph is it is mild, up to 500 you can have in a normal delivery. Mild, moderate, and severe means you can have a blood loss of 1500, you can have blood loss of 2000, you can have blood loss of 3000 ml. And in these conditions, carbetocin acts better than other drugs. We should be quantifying the patients and stratifying the patients according to their risk factors. Like if we have there is a low risk factor, the important is that you have to quantify the patients. There's a low risk factor patient. Among the low risk factors are the patients who have a singleton pregnancy, the patients who are well hemoglobinized, or the patients who have no history of PPH, the patients who have no history of any scar, previous scar means previous cesarean section. These are the patients who are low risk. Then there's the moderate risk patients. Moderate risk patients are those who have a previous scar, are those patients who have multiple pregnancies, are those patients who have chorioamnionitis, are patients who have an IUD, are patients who have polyhydramnios, or are the patients who had previous history of PPH, or are the patients who have a history of family history of PPH. But the severe form of risk is that you have a patient who has more than two or more risk factors of moderate risk factors, or a patient who has a diagnosed placenta previa, placenta accreta, placenta increta, or patient who has a low-lying placenta, or patient who has a low hemoglobin, hematocrit less than 30, and low platelet count less than 1 lakh. These are the patients who have to be stratified, and where you have to make a stringent protocol of minimizing, because we are not discussing about the PPH management. We are discussing about the prevention of PPH. So in that case, the prevention of the PPH is a more important factor. So here, the prophylactic use of utrotonics has to be given. We have applied oxytocin in patients of normal deliveries. We have applied in patients of previous cesarean sections. It was recommended in EU, in European countries. It is still recommended only for the patients who undergo cesarean section. But there have been randomized control trials, and there have been trials going on where it is being judiciously used in patients with normal delivery. So normal vaginal delivery patients can also be given oxytocin, and oxytocin can routinely be given in patients who have, we have seen in our practice, patients who bleed. Once they have been given oxytocin, if we give them oxytocin, we give them ergometrin, and we give them carbetocin. The carbetocin group behaves better in both the things. If so, in conclusion, we can say that carbetocin is a newer drug which has to be given and has to be evaluated judiciously and has been evaluated, but still has to be given under supervision, under caution. But is a new drug that has opened up newer possibilities of reducing the atonic PPH, which accounts for 60 to 80% of all the PPH problems and is the most dangerous of all the forms of this PPH. So, in nutshell, carbetocin is the drug that has to be given, and it comes as a 100 microgram per ml vial and can be used uh, at the time of prophylaxis of the PPH, especially in patients who have mild to moderate risk. Any
Thank you very much, sir. So for how long you have been using carbetocin?
carbetocin we have been using for almost 2 years now.
2 years. And your experience has been generally you use intravenous or intramuscular also?
We use both intravenous
Both.
and intramuscular also, but uh, so ideally the intravenous. Previously, we used to feel that it is 1 ml has to be given slowly. Now we have come up with the thing that we dilute it in 100 ml of normal saline, and that goes in 1 to 2 minutes.
Okay,
That that relieves us with the dexterity of slow infusion
correct, correct.
of 1 ml.
Someone discussing some of your cases, the cases that you have given.
Yes. So if we can we elaborate it?
Yeah,
Can
you
we
can.
make it big?
This is I'm maximizing. This is in,
This one.
yeah.
Make it big. This one.
You want to increase the fonts? You want me to increase the font size?
Okay.
हो गया आपके इधर भी?
If we discuss the cases, we have a case about a 27-year-old second gravida with previous LSS at 36 weeks and
Yeah.
5 days of gestation, reported to labor room with abdominal pain. On examination, she was in labor. Patient had contraction and scar tenderness. Clinical liquor was increased. Fetal heart sound was not present. Cervix was, which was then detected by ultrasonography because of the polyhydramnios. She was hemodynamically stable, but she was in full-fledged labor. Then it was a cesarean section was done and emergency section, because emergency section also is an if we take the high risk factors occurring for PPH during labor are: number one, prolonged second stage of labor; number two, prolonged use of oxytocin for continuous infusion; number three, we have this if there is an instrumental delivery. So these things, they contribute to or you have had an emergency cesarean section. Those are the risk factors for the patient to have PPH, and one we have to be cautious about that. So this was one of the cases where we had an emergency cesarean section performed followed by delivery of the placenta. Uterus became atonic, and patient started to bleed profusely. Sequential uterotonics were administered. Still, patient was bleeding. But then we used carbetocin, single dose carbetocin, and patient drastically recovered, because carbetocin causes both the things. It can prolong the tonicity as well as the rhythmic contraction that can last for hours together. That is the advantage, and that we have used in this case where there were risk factors. Number one, patient was having a previous cesarean section. Number second, patient was having polyhydramnios. So those things made it a risk factor for PPH. So in this case, use of carbetocin was seen and was definitely seen to reduce the blood loss, to increase the uterine tonicity, and it reduces the our endeavor to go for drastic steps like, God forbid, a hysterectomy or uterine artery ligation, or then for internal iliac ligation, and it saved those things. Another case was then
This
there
one?
was a patient. 29-year-old primary gravida female was admitted in labor room with spontaneous labor at 39 weeks gestation. She conceived spontaneously, no history of any medical condition complicating pregnancy. That means we were dealing with a patient of no low risk. Means she was having first primary, she had conceived spontaneously, not with any ovulation induction. Third, she was not having complicated by any medical disorder. Complicated with any medical disorder makes it high risk. So she was not complicated by any medical disorder. First and second trimesters were uneventful. Patient's general condition and vitals were stable. She was well hemoglobinized, and she was in labor, and then she was continuously monitored. And but augmentation and incision means induction and augmentation of the labor also come under the risk for PPH. So she was augmented, labor was augmented, and then third stage was baby. Baby was delivered. Baby was somewhat bigger size, 3,800 grams. And third stage was actively managed. Following the delivery, uterus became atonic and patient started bleeding profusely. Retained tissues and clots in the cavity and cervical tear and other local cause of bleeding were ruled out. To address the bleeding and uterine massage was also performed and administered uterotonics like oxytocin, misoprostol was also given, and but patients still continued to bleed and our BP started to fall. Then patient was given carbetocin 100 micrograms IV administered slowly. Following the administration of carbetocin, there was an initial improvement in PPH with bleeding decreased within 2 minutes. Cross-matched whole blood transfusion was started. Bleeding was arrested in 15 minutes and further invasive procedures were not required. Patient had an uneventful recovery thereafter. So this was a case. So we had a patient who was low risk. We managed that patient with carbetocin. She had atonic PPH, was managed nicely, and the need for only single blood transfusion was there. No multiple transfusion, no multiple tocolytics were used. And in case of previous cesarean section, that had a previous cesarean section had also polyhydramnios and making it a high risk. And in that case, the carbetocin use was found to be very effective in managing the PPH and in reducing the need for drastic steps ahead. So, in conclusion, our experience with carbetocin at our personal level has been an encouraging one and has been a pragmatic one, and has given us more confidence in managing the high-risk patients where the atonicity and the PPH remain a alarming risk.
Thanks, sir. Some of the questions. Which patients can generally get the PPH? We can anticipate PPH in which type of patients?
Yes, that's what we call a scoring of the patient.
Yes, sir.
Means you have a low score, low risk, you have a high risk, and you have a moderate risk. Usually, the patients moderate risk are the patients who had a previous cesarean section.
Okay.
Or the moderate risk are the patients who have a multiple gestation, means two, because they have already the hyperdistended uterus,
Correct.
and that uterus becomes more atonic. Those patients who are having a polyhydramnios, means uterus is overdistended. Those patients who have had a previous history of PPH, that means there has been a problem with the contraction of the uterus. Those patients who have had a family history of PPH, those patients who have a chorioamnionitis, means the infection has gone up. Those patients, yes, those patients who have had an IUD, those are also means intrauterine fetal demise. those patients are also at risk. So once you see these patients, you have to stratify that these are the patients where I have to be cautious, and you have to be definitely cautious, and you have to be definitely ready with all the team for the prevention of the PPH, and even for the management of the PPH in patients those are severely high risk, means
Iris.
placenta accreta patients, placenta increta patients,
And
you have placenta previa patients, you have low-lying placenta, you have the patients who are less hemoglobinized, hematocrit is less than 30, you have a patient who is have a low platelet count. These are the patients who can develop PPH, and that PPH is very difficult to manage. And also, in case of normal labor, as we are managing the normal labor in a labor room, we are monitoring the patients. So what is important is that we have to go through that process, means if the second stage of the labor is prolonged, if we have given multiple inductions, cervical ripening or with some other agents, or if we have had an instrumental delivery, or we are going to do an emergency cesarean section. These are the patients where we have to anticipate at our level. These are the patients who may be having PPH, and we have to prophylactically prevent it rather than manage it. Management comes next, we have to prevent it. Here comes the role of the carbetocin and other uterotonics. Those have to be given just as we manage the active management of third stage of liver. These are the patients where we should be anticipating, yes, these are the patients who can develop PPH.
I mean, you already. Can we use carbetocin in case of retained placenta? What has been your experience, sir?
In case of retained placenta, carbetocin we have not used much in case of retained placenta.
No problem.
In case of retained placenta, mostly it has been seen we have to roll out first the accreta increta.
Yes.
You have to remove the adherent placenta. That is the first thing that has to be done. And in that case, you may not be pulling the placenta more. You pull the placenta, there will be inversion. You pull the placenta, the cord will go, and there will be torrential bleeding. So in that case, you have to be cautiously doing. And number second, the more the intervention is needed in case of retained placenta.
Correct. And in case of Rh negative mothers?
Rh negative means you can give carbetocin. There has been no need to go for this. That means there is a retrograde flow going to the baby. No, you can use carbetocin in case of Rh negative patients.
And this is any specific place for IM according to you, or IV is the best? One should go for IV.
IV is good. IM, yes, IM can be used where you need to have a prolonged action. Because in case of IM, you may have some time for the delayed action. Because IV will give you action in 2 minutes, it may give you action in 4 to 5 minutes. And IV, if in case of IV, the action may last to 60 minutes. It may give you tonic contraction within 11 minutes. But tonic, this rhythmic contraction can occur up to 6 minutes. But in case of IM, it can go up to 3 hours. So the condition where you need to have a prolonged
longer duration of effect.
So you can give an IM dose of oxytocin in those cases.
If a patient is not responding, I mean, you have already used carbetocin, what other additional nutrients? So it would be everything that you would use.
Oh, yes. If
no
carbetocin is not, yes, you can use ergometrin, you can use misoprostol. You can use the other surgical methods, like you can use the uterine artery ligation. If it is not helping, you can use the bilateral internal iliac ligation. But every time one has to be focused that we have to save the uterus. This is an era of saving the uterus rather than era of doing a peripartum hysterectomy.
Absolutely. And we have already seen advantage of carbetocin over other drugs. Any specific oxytocin-related side effect you have seen, ADH-related side effects, especially water retention?
Yes, it can lead to water retention. It can cause bloating. Yes, definitely. Sometimes you may, if it is prolonged use, sometimes after delivery we may have to use less X to reduce the burden, and it remains in your background that sometimes it may decompensate the patient because of the volume overload.
Correct.
And that's a very important adverse effect that is not with carbetocin. That makes it very advantageous.
That's an advantage.
Yes.
Should carbetocin be kept as a reserve drug, or looking at the dangers to use?
Ideally, carbetocin in our settings where we have the less resources, where if you see in most of the things, we should not be saying my hospital is equipped with blood bank and other things, but there are only some percentage of deliveries happening in a good
Yeah,
hospital
yeah,
where you have all the setup available. I suppose this should be the drug. Only thing is that the cost,
correct,
because
correct,
the previous we used to say that there have been good amount of and credible trials going on where it has been found more safe compared to ergometrin and even oxytocin infusion in case of
oxytocin.
cardiac
Yeah,
patients. It has been seen now even in case of preeclampsia patients it has been seen to be safe. So I suppose it should be considered to be the first line drug in case of prevention of PPH even in the remote areas, and best in those areas where, because
power
prevention
outage. Yes,
better than
correct,
the
correct,
in those
correct, correct.
patients.
And
The
looking at
moment they shift the patient to the other area, they shift to the higher centers, the patient collapses.
absolutely, and looking at this, the possible danger that can happen, it's better to use the best drug first.
Best drug first and preventive measures first.
Correct, correct, correct. I mean, one last question I will ask you. Your one liner on carbetocin, take home message.
Carbetocin is a good drug. In our settings, it has the advantage of being not to be stored at a particular temperature. Very important, makes it a predictable, actionable drug. Second, the dose fixity means in case of carbidosis, in case of oxytocin, other thing, you have to have a continuous infusion that is dose and response related. But in this case, you have a fixed dose. You are not at any confusion. Third, you have the decided routes. Fourth, it has it has less side effects compared to oxygen. Fourth and most important thing that we are afraid of is that it is divide or least affinity with the V2 receptors, so that the already congested maternal body, already congested maternal hemodynamic system should not be over congested. That means
Correct, correct.
anti-diuretic effect is least. So we should be using carbetocin, but only thing is that we request all of you to reduce its cost so that it becomes affordable to all of us. That's the only
Thank,
thing that makes sense.
thank you so much, sir. Thank you for your insights. It was wonderful, hearing those case studies where we expect the unexpected. Thank you so much. Carbetocin having saved lives is wonderful. Thank you so much for your time, for your cases.
Thank you.
You can log
Thank
out,
you.
sir. Thank you so much.
Thank you.
Thank you. Shashidhar, we can log out now.
Sure, sir, definitely.